Uh, Joseph Wasserman was president and chief executive officer of Lakeland Healthcare, now Corewell Health, for 25 years until his retirement in 2009. He received his BS from the University of Toledo and a master's in health administration from the University of Michigan. Paul Clippinger has served as executive director of Holland PHO, a network of physicians affiliated with Holland Hospital for the last 10 years. He received his BA from DePaul University, AUW, not AUL, and a master's in health administration and master's in professional accountancy from Indiana University. Please, and we will begin with Mr. Wasserman. He will give the big picture approach, having led a large health system, and then Paul will get into a lot more detail. So please welcome our two presenters.
Okay, well, good morning, everybody. Good morning, Zoomers, wherever you may be. As Randall mentioned, I'm Joe Wasserman. I would also add to my resume that I served as vice chair of our county health department, Berrien County, for over 10 years. So it kind of gives me that perspective as well. As you said, I'm a former CEO. So now I have to say that I'm more of a consumer of healthcare than a provider. Over the next several minutes, I'm going to present an overview of our healthcare system here in the United States. And then I'm going to leave the Affordable Care Act to Paul, our expert over here, who knows far more about that than I ever will. So I'm going to review facts and data on the status of healthcare in our country. And then I'm going to leave it up to you all to draw your own conclusions and opinions of how good or bad or expensive or whatever we are. I should explain my bias, because everybody has a bias. And my bias is that we focus way too much on treating illness rather than preventing illness. So I'll use an example of your automobile, your car. If you compare healthcare with your auto repair shop, your car dealer, you know, if you maintain your car and you drive safe, what happens? You have far fewer car repairs, you have fewer accidents, you save money, you have fewer injuries and deaths. And I think the same is true with healthcare. The public health measures that we've experienced over many years has historically had significant greater impact on morbidity and mortality than all our medical interventions from our hospitals and our doctors. So consider environmental standards that we now have for clean air and clean water, behavioral changes in diet and exercise and smoking, the public safety regulations for the food we eat and the chemicals that we're exposed to, and workplace OSHA regulations to protect employees at the workplace. And also think about antibiotics. Penicillin has only been in use since 1941, I think is when it began. And use of vaccines, widespread use of vaccines, only began in the 70s. And you think about what cost that is, minimal cost, and it has literally saved millions of lives. I know many of you probably know your parent, maybe a parent or a grandparent that died of some disease now that just it wouldn't happen. Our present healthcare system is very complex. It's costly, as you'll see. It's multifaceted. There's a lot of financial considerations with it. There's structural issues that we have and kind of embedded in our health system, and certainly politics, as we know just from recent events. In the United States, 30% of our healthcare spend is on overhead, just paper shuffling, if you will. Not that some of it's obviously necessary, but in Europe, it's only 15%, or actually less than 15%. So healthcare is very different than most other businesses that you're familiar with, because we don't operate as a normal business would, that are governed by supply and demand, by pricing or competition. We don't have those same factors the same way that normal business does. So prices and quality are very obscure, and in most cases impossible to determine. Most people don't shop for how much is this ER visit going to cost, or whatever. And most of us have insurance as a buffer. So as I mentioned to Paul earlier, those of you that live here around in Holland, you're blessed by having a very good healthcare system here locally. I do delve into a lot of this esoteric data, and I can tell you Holland Hospital is one of the best in Michigan. So you're very fortunate in that regard. So let me begin with my slides. So what we'll be talking about over the next 10, 15 minutes or so is how are we performing as a healthcare system? How healthy are we as a country? How much are we spending on healthcare? How are we insured as a nation? And then how are we going to deal with future issues and concerns? So not exactly a fancy graph here, but this shows the kind of pecking order of 10 different countries, mostly all developed countries, and rank orders them and how they stack out against other countries and us. And if you see, we're last, number 10. But if I were to have a graph, which I don't, you would see a cluster of those other 9 on top, and we would be all the way down to the bottom of the page. So we're not only the last of those 10, we're really last. So what does that mean to us? Well, if you look at our life expectancy, I've just exceeded it, by the way. The life expectancy of 77 is the lowest among, developed countries. We have the highest infant mortality rate, and double the rate of preventable deaths and maternal mortality. We have significant racial disparity in this country. If you're Black, your life expectancy is 4 years less, and if you're Native American, 7 years less. 30% of the adults have multiple chronic conditions, and some 40% of the population is obese. And in fact, I just saw this morning before I came here, they said the statistics show that actually 70% of people are either obese or overweight. Pretty significant impact on health. Mental health issues we have are the highest of all those developed countries, and we have the highest suicide rate among developed countries. In fact, I think the data would show that about 1 out of 4 adults in the U.S. have had at least one mental health episode that needed to be treated. So what factors, why is that? What are the factors that impact health status? Genetic is one, and that's, at least up to now, there's not a whole lot you can do about that, but that's changing. As you know, they have that CRISPR technology and whatever, and they'll actually are working to be able to do some genetic changes to alter that. Race, if you're a minority, you're going to be less healthy. Income, lower income, less healthy. Geography is interesting because if you're fortunate enough to be from Hawaii or Colorado, you're going to be a lot healthier than us here in Michigan. And geography is not just what state, but it can be if you're in the inner city, maybe exposed to more chemicals and smog or whatever, or if you're in a rural area and don't have access to healthcare or next to a bunch of farm chemicals, you're going to be at more risk. Educational level, I mentioned obesity, your insurance. Paul will be talking shortly about the ACA, and I'm sure he'll talk about how that's really helped literally millions of people in our country to get better access, better insurance. And social support. It's good to be married because you're going to live longer. And also it's important if you're near family and you have family support and social support. Those are all, and of course, last there, and maybe one of the more important factors, age. You get older, you know what, we start falling apart, whether we like it or not. How are we spending our money on healthcare? Well, Medicare is going to go over these quickly, but it's about 20% of the spend. Medicaid a little less. Private insurance is the largest component. That's about 30%. And interestingly, the employer-based family coverage that either you or maybe your family has, the average cost is over $25,000 a year. Out-of-pocket cost is about 10% of the spend, and that would be your copay, deductibles, over-the-counter drugs, self-pay, maybe you go to a chiropractor or something that isn't covered by insurance. Our total spend is $4.5 trillion, and it's about a little over 17% of our gross national product. We spend in the US about $6,000 more than other developed countries. So, which is interesting. So we're spending $6,000 more, but our healthcare, the health status is worse. Interesting. That money, most of that money is spent on outpatient and inpatient services. So, what is our expenditure by type? Hospital care gets 37% of the money. Physicians and clinical services, about a quarter of that. Prescription drugs, about 12%. And then you can go down the chart there, dental, home health, and all are more minor parts of our expenditures. How are we insured? 92%, it's estimated, have some level of health insurance in the United States. The employer provides over half of that insurance. Medicaid and Medicare, pretty much about the same, 20%. Direct care, that's just you pay it right out of your pocket. It's about 10%. And miscellaneous is 7%, and that's like TRICARE with the soldiers and what have you. Each segment, though, whether it's Medicaid or Medicare or private employer, generally have different plans. Some have fee for service, which we knew and loved, still have it. But some are part of an HMO or PPO or some other alphabet soup where they have some restrictions or changes that you need to follow. And done that mostly to make it more efficient and less costly. The uninsured are primarily low-income households under $25,000 that make up that 7%. Typically, it will be Black and Hispanic working adults are most likely to be uninsured. One thing that you maybe don't hear a whole lot about is medical debt. There's billions of medical debt out there due to inadequate insurance. Really don't know that amount because it's just not collected, but I do know that it is the single most common reason for bankruptcy of individuals. So let's talk a little bit about Medicare and the Affordable Care Act. And it's going to be a very little bit about the Affordable Care Act because expert over here is going to do a great job explaining that. The Medicare enrollees in 1973, I think Medicare started in 65, but 73, there was 23 million enrollees. Now, this year, last year, I guess, there's 3 times that. There's 67 million, and it's projected in another 30 years, it'll be about 90 million. The premium and payroll taxes fund about half of the cost of Medicare. The expenditures in this is all like a year ago data, but it was 840 billion, and it's about 14% of the federal budget. Medicare, I think I mentioned this earlier, is about 20% of the healthcare spend, and it covers, as I said, about 20% of the population. You probably know this, but the components of Medicare, A is hospital care, and everybody gets that, you're entitled to that. B is the doctor fees and other services, and you may be paying a premium for that. C is Medicare Advantage, and that really covers A, B, and D, and D being the prescription drug Medicare benefit. Interestingly, about half of the Medicare enrollees are in Medicare Advantage, and it's been growing. So Medicare, there's a tax that we pay, we did pay when I was working, and it's about 1.5%, and it's matched by the employer, and it is capped at the, I don't know, like 150,000, something like that. And then if you make more than that, you don't have to pay it, at least not yet. The premiums cover only about 15% of the Medicare expenses. And what is Medicare? Where does the money go? 40% on hospital care, 25% to the doctors, and 35% for drugs and other services, physiotherapy or what have you. The trust fund is projected to be depleted by 2036 in about 12 years. And if it isn't fixed, yeah, which it probably will be, but if it isn't fixed, they would have to cut Medicare spending by 10%. Medicare Advantage, you see this on TV more than you want to if you're watching television lately. It generally is low or minimal premium, and they entice you with extra benefits, maybe prescription glasses or whatever. But they generally, not always, but generally have some significant restrictions. You don't have to go to certain providers. You might have to get your primary care doctor to approval before you go see a specialist, that sort of thing. The Affordable Care Act, I'm going to just briefly cover this because you're going to hear a lot more about it. Individual purchase coverage through what's called a insurance marketplace. There's about 20 million enrolled. Most of the enrollees receive some kind of a premium tax credit, so it's subsidized by state and federal government. It generally provides a private insurance option for those in lower income population and not covered by the employer or Medicaid. And again, sometimes limited benefit and some deductibles and other restrictions. So let's compare ourselves with Europe. Europe primarily uses taxes to pay for healthcare. Most of the countries have pretty much close to universal coverage. We use private insurance, out-of-pocket costs, and government spending. Europe has more equal access regardless of your income and social status. Although in recent years, some people now are buying, if you can afford it, supplemental insurance, so they don't have to wait in line, which I'll talk about here in a minute. Europe, the administrative cost is much less, as I mentioned. Pharmaceutical prices are much higher in the US because Europe regulates prices. We do not. The waiting times are much longer for Europe for non-emergencies. So if you need an MRI or a CT scan or a non-emergent surgery like a knee or a hip, you can wait months, maybe even years. The healthcare outcomes, though, interestingly, are actually better in Europe than here. That isn't necessarily a indictment on the healthcare system. It's probably more of an indictment on our healthcare status. We're just not as healthy as they are. We do excel in research, in specialized care, and high quality medical facilities like you have here in Holland. How do we deal with future issues and concerns? Are we going to bridge the gap between cost and outcomes, which I've discussed earlier? What is the role for public health to improve outcomes? It's been pretty significant in past years. What's its future? And are we going to make the investments that maybe we need to for public health? Medicare finances and the ACA subsidies. There's a lot of political maneuvering on that, and I'm sure, again, Paul will be talking about that some, especially with the ACA. Will healthcare need to be rationed? We find that something like 25% of all Medicare expenditures is in the last few months of a person's life. So are we prolonging life, or are we just prolonging death? Or really, how much are we benefiting? We are seeing more attention paid to that with hospice programs and so forth. And some new drugs. And some of these drugs can cost $100,000, $200,000 a year. Are we just going to, if it's invented, are we just going to pay for that? Is there going to be any restrictions or limitations? We don't know. The impact of technology and AI, that I think is a lot of thought about how that can just transform healthcare in various ways. Nowadays you can, if you get an X-ray or a breast mammogram or something, the computer can actually read it now with more accuracy than the radiologist. Hopefully there's no radiologist in there. That can be really monumental, and it could have the impact of lowering costs, but it can also raise costs as we have new technologies. The staffing shortages. I don't know how it is here in Holland, but physicians, nurses, and other healthcare workers, there's projected to be a significant shortage. Aging population. It showed you the statistics of the enrollees in Medicare, and it just shows you the exponential growth. And as we know, you get older, you're more frequent flyer when it comes to healthcare. Access and affordability. The prices moderated some in the last few years, but with shortage of personnel and nurses, you can expect wages to go up. And, are we going to be able to afford all the care that is going to be needed? The racial and economic disparities, should a person be less apt or access to care because of their income level? If you're higher income, you can get the care. If you're not, well, good luck. That's an issue, I think, for our country. Our administrative complexity and costs. What are we getting for that? We're paying 25% or so overhead. Europe 15%. What are we getting for that extra 10%, 10-15%? Which comes up from time to time. Are we going to move to some kind of a Medicare for all? So a lot of statistics, some questions. I wish I had the answers. I don't. With that, I'm going to turn this over to my colleague, Paul.
Yep, there we are. All right. Good morning, everybody. So I'm going to get into a little more detail with regard to the Affordable Care Act and kind of talk about some of the objectives of it and where we are with it at this point in time. There were some different objectives with regard to the plans, Affordable Care Act. One was to increase the number of people covered by insurance. Another one was to expand the number of people eligible for Medicaid. And then there were some other nuances to the plan in terms of improving efficiency and improving quality. I'm not going to focus on those elements of the program. I'm going to talk more about the act as it related to health insurance coverage for individuals and where we are with regard to all of that. One of the pieces to the plan, the Accountable Care Act was initially signed into law in 2010 by President Obama, and then various elements of the plan were phased in thereafter in the following years. And so one of the features of the plan was to provide incentives for the federal government to help fund Medicaid expansion within the states. So historically, adults, low-income adults, did not have eligibility for Medicaid. And so what the federal government did as a part of this whole program was that they said, all right, we will fund a large portion of your expanded Medicaid coverage if you will raise the eligibility to 138% of the federal poverty level as opposed to 100%. And so basically that broadened the net of people that were covered by the Medicaid program in the various states. Most states adopted that. Michigan adopted that. There are some states that didn't, but generally that was one element that helped expand health insurance coverage for people across the country. Then when you think about the individual and people that might be struggling as an individual to find health insurance, the Accountable Care Act, the Affordable Care Act, that they had some carrots and sticks, some incentives and some penalties associated with the plan as it was first developed. So one of the things that they did is they created premium tax credits. And so kind of on a sliding scale, depending upon what your income was, there was an ability to subsidize and lower the premium that you would actually have to pay by the government providing some funding for a component of that premium. Another thing that they did for lower income individuals is that they lowered the co-pays, the co-insurance, the deductibles associated with the lowest income individuals So again, that healthcare could be more affordable for those individuals. On the other hand, with regard to some of the sticks that were associated with the plan, one was they established open enrollment periods and rules associated with that. Because just think about it. If you could sign up for health insurance whenever you wanted to, you'd wait until you were just getting sick and not pay the premium in the meantime and just sign up at that particular period. And so there were some rules about when you would be eligible to sign up for the plan to try to get more people to participate. And then beyond that, there was an individual mandate, which I'm sure you all remember, with regard to there was a requirement for a period of time that everybody have health insurance. And if they did not, that there was penalties that would be assessed via your federal taxes if you weren't a part of if you didn't comply with the individual mandate. Incidentally, there are still states that do have an individual mandate at the state level as opposed to at the federal level. So let me introduce you to my three people here. So this is Mr. Healthy here. And he works out every day and he's got great genes and so this is Mr. Healthy. Mr. Average is kind of your average run-of-the-mill guy and he's not super sick, he's not super duper healthy. He's kind of the middle of the road, kind of the average person. And then we've got the unhealthy individual because of the genes, lifestyle, or whatever that they're pretty unhealthy. So let's talk about how health insurance works. So you get this pool of people and you have them all participating in the healthcare program. And then you see what the cost is going to be for that total pool of people. And then you divide that by the number of people in that pool. And then you kind of have the average cost per person. And then the insurance company has to have some overhead associated with that because they have to administer the claims and take care of everything in terms of your benefit cards and all of that. And so you add that company insurance and you come up with an insurance premium. So that's kind of the basic concept, is you're spreading the risk over a population to moderate what any individuals might have to bear with regard to that. So you see, you got these different costs associated with these different individuals. And because you got those healthy and those average people in there, that it kind of moderates what the premium is going to be for the parties that are involved. So now let's talk about some of the elements that were or continue to be a part of the Affordable Care Act and how they impact things in terms of this whole concept of insurance. So if you think about this individual mandate that has now gone away, but when that individual mandate came in, the concept with regard to that is you want to have those healthier people in your pool because you want to be able to kind of moderate the expenses for everybody. So you want to try to get those healthy people in the pool, and then it's not super expensive for anybody by getting those people in the pool. I'll talk more about the lifetime limits here in a minute. Well, as you all probably remember, back in 2017, the rules changed where the IRS no longer enforced the mandate. They no longer applied the penalty. And then by 2019, I think they'd fully repealed that. And so other than those individual states where they still have some mandates going on, people who are super healthy are now less inclined to want to be able to buy that health insurance because it's expensive and they're super healthy. Why the heck would they pay for this health insurance? Okay, so you've lost those people out of that pool. So now if you think about the impact with regard to the overall cost per person, you've lost some of those people with regard to the removal of them from the mandate. They certainly can continue to participate, but they may choose from their own financials that it's not worth their while to. So you've lessened the pool and the cost per person is going to go up. Another piece to the whole program was that they got rid of, as a part of the whole affordability, the act, that they got rid of the pre-existing conditions. And they started mandating that there would have to be a certain level of benefits for individuals. They got rid of pre-existing conditions and they got rid of lifetime maximums. So think of Mr. Unhealthy there. So there might be pre-existing conditions in the old world that wouldn't have been covered. Well, those are going to be covered now. So think of lifetime maximums. Under the old world, once you reached a certain dollar amount, that the insurance company was not going to pay for those anymore. In the new world, all of that stuff is covered. That's good as an individual because I want to have full coverage and not have a max with regard to that. And I don't want to have things carved out. From the standpoint of the overall pool, that raises the cost for the pool overall because more things are being covered than used to be covered. One other piece with regard to the legislation related to what benefits had to be required. So in the new world with ACA, pregnancy coverage had to be in there. Hospitalization coverage had to be in there. Free care associated with preventive services had to be in there. Mental health services had to be in there. So in the grand scheme of things as an individual, those are all good. And probably in the long term, in terms of healthcare lifetime costs for an individual, by providing them all of those things, it's probably going to make them healthier in the long run. But think about the old way it was, which is what's shown on the graph here, in terms of the expenses weren't as high in terms of the premium because you weren't getting as much for your money. So now the good news is people are getting more for their money, but it also means that there's more cost associated with that healthcare because more things are being covered than what they used to be covered. Another nuance, it was mentioned earlier with regard to the overhead in healthcare and so on. And so one of the rules that they set with regard to this whole ACA insurance offerings is they said, okay, we're going to cap the amount of dollars that you can spend for overhead. And if you spend more than that, you're going to have to refund money in terms of the premium to individuals. And so the idea was that the insurance companies were not keeping too much in their pocket for either profit or their overhead in terms of processing claims and so on, to try to help keep the price of the insurance premium down. So now we're going to kind of transition a little bit in terms of how this was all implemented. So I'm Mr. Potential Prospective Enrollee, and I'm getting ready to shop for health insurance, and I'm out there on my own. I don't have eligibility with Medicare. I don't have eligibility through my employer. My employer's too small. And so where do I go? Where do I find health insurance? It's not easy to find health insurance if you're a onesie kind of a person, because nobody's super excited about selling you that health insurance because of random variation. And if you're looking for health insurance, you very well may be sick to begin with. So the government created this healthcare.gov, basically virtual website where you could shop for this health insurance. Some states did their own shopping location. And so what you can do is you can look at the different plans. There's bronze, there's silver, there's gold, there's platinum. So you're shopping on healthcare.gov. Well, am I eligible for it? Well, if I'm a U.S. citizen or I'm a legal resident, I'm eligible for it. If I don't have insurance available, if I don't have insurance that I'm covered by through my employer, I'm eligible for it. So now as I'm making my decision, here's what I have to think about. You've got the two ends of the continuum in terms of from the bronze to the platinum and everything in between, in terms of how much out of pocket do you want to pay versus how much premium do you want to pay. So at the bronze end of the options, you're not going to have a very high premium, but your co-insurance, your copay, your deductibles, et cetera, those are going to be really high because there's not going to be as much of that's going to be covered by your health insurance. On the other end of the spectrum, you've got platinum. Well, your premiums are going to be super duper high, but you're going to have very little out of pocket if you choose that as your option. So overlay some of the additional features of the ACA on this. One of the things that they did was they said that, okay, depending upon your income, and where you stand with regard to federal poverty level, we will provide a premium tax credit for you. And so what that means is whatever those monthly premium costs would be, that the government would subsidize, and it's on a scale, a component of that premium to help keep your premium costs down. So that was one additional feature that came in with the ACA. Then another feature that went in is for lower income individuals, and this only applies at the silver level of benefit coverage, that they said, okay, well, if you're low income, probably it's going to be hard for you to afford copays, deductibles, and coinsurance, even if you've got silver coverage. So what they did is they said, depending upon your income, we'll go so far as we'll adjust those copays, deductibles, et cetera, that they look more like a gold or a platinum level of copay or deductible or coinsurance to help, again, reduce the out-of-pocket for lowest income individuals. So what has this done? What have we accomplished? Where are we with regard to what has happened as a result of the Affordable Care Act? So if we think about, okay, we've increased the number of people that are covered by insurance. Now, how have we done that? There's several things that have happened. First of all, there was a employer mandate that went into effect in 2015, which said that, okay, if you're an employer of 50 or above, you have to offer affordable health insurance to your individuals. So that helped increase the number of people on insurance. Another thing that went into effect, I think back in 2010, was they said, okay, you can, as a child, your child can stay on your health insurance until they reach age 26. So that was another way things were expanded in terms of the number of people that were covered by health insurance. Another way that it was expanded was this Medicaid expansion that I mentioned, in terms that the federal government helped subsidize at the state level an encouragement to broaden the number of people that could be covered by Medicaid. And so that was another nuance that helped people out. And then finally, with regard to this marketplace that I'm talking about and the subsidies, this allowed people, A, a place to even find the insurance, and B, mechanisms to kind of subsidize the cost of that insurance so more individuals could be covered by that. As a result, we've got fewer people that are uninsured, and I'll get into more of that on another slide. Another thing that this did, and I mentioned this earlier in the presentation, was so now all of the people with pre-existing conditions, now they can still have coverage for those items, whereas in the old days, you couldn't get coverage with regard to those services necessarily with regard to your health insurance. This is just a map and kind of refer to the table at the bottom to kind of give some perspective from an income level of where people fall. Certainly there's higher income people that are eligible to be able to participate on the individual exchange in terms of buying health insurance. But you can see that 200% of the people, almost 50% of the people that are accessing the marketplace product are at 200% of the federal poverty level or below. So it's not uncommon for health insurance plans that specialize in Medicaid to also market these marketplace products, because it's frequently kind of those people that are right on the border that maybe some of the time they're eligible for Medicaid and some of the time they're eligible for marketplace. So it's kind of a niche that the Medicaid providers are in, that they kind of work in this same space too. So to where we are right now, about 5% in 2023 of Michigan was uninsured. Prior to the marketplace, that was about 11%. So it's been really successful in terms of reducing the number of uninsured folks. In addition to that, you can see that about 4% of the Michigan population is associated with the marketplace program. In our market, you can see 21 million people nationally covered with the marketplace program. Michigan, about 420,000. Ottawa County, about 12,000. So that and it continues to grow year over year in terms of the number of people that are participating with regard to this offering. So where do we go from here? What's going on? What are some of the problems and so on? I showed you kind of the business case and issues and challenges associated with the plans. So there's no more mandate. So some of those healthier people aren't buying out of that pool anymore. That makes it harder for the insurance companies to offer a product with an affordable premium, even with some of those subsidies that are out there. The inclusion of those pre-existing conditions and more healthcare benefits, I think that's great, and I think it ought to be there, but that makes it more challenging. Think of all those things on those charts I just showed you from a business model perspective and an insurance company perspective in terms of how are they going to make ends meet. And then on top of that, the government is saying, okay, you can only spend this amount on your overhead and maybe a little bit, which would include your profitability and everything else with regard to that. And you're taking this risk with regard to this population. So that from a business model standpoint, that makes it challenging for the insurance companies. And what's happened in some markets is they barely have any insurance companies left in a particular market that are willing to offer that insurance because of all of these business dynamics of this business model. And then, of course, you've got the back and forth between the Democrats and the Republicans with regard to should we get rid of ACA, should we not get rid of ACA, what are we going to do with that on a go-forward basis. I can't in my wildest dreams, there's so many people on it, see that it's ever going to be gotten rid of. There's so many people that benefit from it. I regardless of which administration there is in power, unless they find somebody comes up with a silver bullet in terms of a better replacement for it. I mentioned the individual mandate that had been removed. That was one of the developments as the program went on. It continues to kind of be a challenge to be able to spread that risk. Medicaid expansion was done in most states, but there's still holes where the Medicaid wasn't expanded and maybe the marketplace doesn't meet the needs with regard to those populations. So there's states where there's still issues with regard to that. President Biden during COVID, another development that had occurred was that they had expanded the open enrollment period to try to help people during that health crisis to get more of an opportunity to get signed up for health insurance. Generally speaking, the plans have been pretty successful, and as you can see, in terms of lowering uninsurance and getting people with insurance. The business model is still shaky. I showed you kind of the business model on that, and it's shaky with regard to trying to make ends meet on this from an insurance perspective with regard to this. Some of the things that are already being kicked around that the Trump administration may be looking at is, remember I talked about that cap on the overhead for the insurance companies. That's being contemplated in terms of whether that might be changed, either to remove that cap or raise that cap. And that might provide the insurance companies with more incentive to be interested in staying in this line of business. So that's one thing that's kind of being kicked around. Another thing that may be getting kicked around as we go forward with the changes in administration is, remember I talked about that subsidy that the federal government is providing for Medicaid for the state plans to have that get the up to 138% of the federal poverty level. Well, as they dig deeper into that, what they're finding is the math on that doesn't work out for the federal government. It would be cheaper to move them over to the marketplace product, maybe help them out with some of the subsidy on that end than it would be to keep some of these healthier people in the state's Medicaid program. So those are two things I've heard of so far in terms of potential things that might be pondered on a go forward basis with regard to that. And with that, I am done, and I'll open it up and see what questions you all might have for us.
Please raise your hands and wait for the microphone so that the people joining us virtually can hear your questions.
Very good presentation. I appreciate that. Two questions that relate more to Mr. Wasserman's statistics than maybe, and it really is for you all. Two of the exacerbating factors about our healthcare system is it's expensive. A large portion of that's administrative expenses, and our outcomes are less than what's called desired, right?
Right.
Has the ACA had a positive impact or a negative impact on those two numbers?
Well, I think Paul could answer that, but I'm an advocate of the ACA. I think it has been very helpful to our country to have access to care. But I'm going to defer that to you.
Some of the arguments are that it's done some things with regard to a little bit of improvement and a little bit of bending the cost curve. Some of the articles would indicate, well, it's more of a what if. What would things look like with regard to if those things hadn't been done? And so some of the studies indicate, because a lot of what it has to do when you talk about healthcare, especially when it comes to cost of healthcare, is it's more about bending the cost curve. If things are going in this direction and you're trying to take it in this direction. And so some of the articles and so on would say, okay, it has some impact with regard to doing it like this. It may have had some impact on quality too.
There's no real study which says we spent all this money, we've instituted all these programs with the goal of improving healthcare and lowering costs. Has that effectively been?
Yeah, the quality one, I'm not quite as in tune with what they're saying in that space, but on the efficiency standpoint, they're saying that there's been significant change with regard to the trajectory, with regard to some of the rules and regulations that they put in place with regard to the plan.
So related to costs, the Affordable Care Act didn't really address the cost structure of healthcare. It was really looking at insurance markets, correct? So I don't know if either of you can speak to sort of how we pay healthcare providers in the US. You know, we pay a lot more for procedural care, for specialty care than we do for primary care and other types of care that would help people be healthier. So in terms of the last question, as it relates to costs, the ACA didn't really address those issues. And is there any energy, I think we know the answer to this, but is there any energy in the federal government to do that? I mean, the reason that healthcare is more, well, I don't want to say it's more affordable, but it's lower in European countries is because it's more highly regulated. And some of those issues are addressed, but we have a reluctance here in the US to impose more regulation. And there's a lot of obviously strong lobbying power against that in Washington. So are there any efforts that you're aware of to address that cost structure, which is really the only way we're going to address the total cost of healthcare, or one of the major ways we would do that?
Yes, I could talk all day on that. So in the organization I run, I spend a lot of time in the Medicare Advantage space, and about 75% of the lives of the senior lives that are associated with my organization are in Medicare Advantage as opposed to traditional Medicare. So here's where the government is going with regard to all of this. They're saying that, okay, we don't want to take the risk of a fee-for-service world with regard to the cost of Medicare. And you could take this down the road in terms of how various organizations like ours that are working with health plans in the commercial space too. We don't want to take the risk for the Medicare spend. We're paying fee for service. There's no controls on that. Every time somebody walks in the door, you know, you ring up another charge with regard to this. So here's what we're going to do. Health plan, we're going to give you this much money for this age patient, for this severity of illness patient. And that's it. And you manage it. And oh, by the way, we will give you even more money if you do really well on quality, and we will give you way less money if you do bad on quality. So that quality gate is the accountability to the health plan, because you could say, okay, well, I'll never deliver another piece of service, and boy, I'll make out like a bandit. That doesn't work that way, because there's an accountability in terms of the quality performance expectations from the government with regard to that. But basically then the providers are given a budget, and then it's up to them to try to manage the care. So are we having enough visits for our more severely ill patients with their primary care patient? Are we targeting those people, getting them in on a more regular basis, making sure their meds are managed right? Are we doing the assessment with regard to their chronic kidney disease so that they don't have to go on dialysis? Are we working with the patients in terms of getting them on a palliative care and a hospice track, if that's the point of where they are with regard to their life? Are we working to get people into a less cost intensive setting? And then to your point, one of the concepts in the world that I work in is a patient-centered medical home. And the idea that is the primary care physician is the quarterback with regard to your care, and you want to make sure that they're adequately managing the overall care of the patient, and there's care managers within their practices and so on to try to optimize the patient's health, the quality metrics of the things that are they getting their mammography? Is their diabetes being managed appropriately? There's a whole list of things that are tracked with regard to that. So that's conceptually where we are. One of the challenges at this moment is there's 1 foot on the dock and there's 1 foot in the boat with regard to the old fee-for-service world versus this other world of where we're moving.
Yeah, I'm not as optimistic as Paul probably. I agree that those would be very good direction to go, but our system, for one, the politics, the lobbying with the drug companies, the insurance companies, the physicians, the aggregation of health systems, we don't operate under normal, as I said, competition. If I want to go out and buy a car, I can do all sorts of research, infinite to buy. When I pick a car I want, I can see the track record, the number of recalls, the safety thing. I can't do that with going to find my doctor. I'm clueless. And there are some, you have to post your prices now, but nobody looks at them. And they're incomprehensible anyway. So you're not price competitive. You don't have good quality measurements. Our system is not functioning real well, and Paul gave a number of strategies that would make that better if we could do it. But I'm going to tell you, you got Medicare, you got Medicaid, you got 50 different insurance companies, you got the ACA, you got the pharmaceutical companies. I shouldn't use an example, I will with my wife. She has to take a statin drug, and the drug that she takes, she has to use a brand name because, which I won't mention Crestor, but she has to take that brand name, and the cost of that is something like, I think it was $500 a month. So she can't, if she takes the generic, she has a reaction to it, which many people do, joint pain. So smart me, we get it from Canada. So they ship it to us, $25 a month. I don't think they're losing money sending it to Canada. So I mean, that's just one example of lobbying that goes on. And there's so multifaceted, so many hands in the cookie jar that I don't know if we have the will to make the kind of changes that we do. Sometimes in the past years, they threw up their hands, let's just go to national healthcare. I don't really want to see that, but who knows? But I think Paul laid out a lot of good strategies for that. One of the things that I've always bugged me too, or bothered me, was that if I got caught driving my car and I was drunk, or I got 2-3 accident or whatever, they raised my premium. Or if I want to buy life insurance and I weigh 500 pounds, they're going to probably either not insure me or make me pay a lot of money. The healthcare, they don't care. It's just, there's no penalty. So if you're obese, should there be an obese penalty? Or if you don't take your medications properly, obviously genetics, that should be off the table. But if you're not controlling your diabetes or whatever, should there be some kind of a penalty? You pay more for your insurance or your benefits go down. I don't know. I mean, that's one thing that can be done, but it's going to be a monumental task to implement many of the great suggestions that Paul mentioned.
We have a remote question from our virtual viewer.
The question is, you kind of talked about it a little bit, but what specifically would you do if you ran the world, for healthcare and insurance?
Ooh, you do that.
The drug cost was mentioned. The drug cost is out of control. And I mean, as I look at the budgets that I have to deal with regard to it's just astronomical. The good news is there's all these new things that are being invented all the time that are adding opportunity for all of our health over the long term. But the size of the cost with regard to that, and it doesn't even seem that the insurance companies are powerful enough compared to the drug lobby to be able to make much in the way of inroads with regard to this, because they're all struggling with it too. That's one area where I would try to do something to rein that in. I don't know how you fix it. The obesity epidemic in our country is cataclysmic in terms of where this is going and how we need to address this. And then you get back into the drug costs, because some of the insurance companies were coming down the road in terms of, well, if nobody will do what they're supposed to do in terms of their weight, then I'll give them a bunch of drugs. And then they started looking at what this was doing in terms of their budget with regard to the drug costs. And they said, whoa, we can't do that. So trying somehow to get people to take in more accountability for their own health, I think, is going to be essential.
I wish I knew an answer to that question, because it's a great question, because I don't think anybody really does have a solution to that. I think there maybe is two different directions you can go. Like Europe has gone more to single care, national health care type insurance. We've decided we don't want to do that, that we want to have more the competitive model, although it's not really competitive in certain respects. So I don't know. There's a lot of issues. We have Europe is a healthier community. We just got back from Germany. I mean, you don't see people look healthier there. I don't know that either they have, I don't know if people are like Canada or in Europe, would we tolerate waiting 6 months or 8 months for an MRI or a CT? We're a very impatient country. We want it like right now, or to wait for 1.5 years for a knee replacement. They're very good if you're going to go and get in a car wreck or have a heart attack, they'll take care of you fine over in Europe. But for a lot of this elective care, we're kind of an impatient people, and I don't know if we would put up with that. I myself, the Medicare Advantage, I call it, the most, I have my own term for that, Medicare Disadvantage. It's fine for some, but if I have something esoteric wrong with me, which I probably do, but if I have some problems and I want to go to Cleveland Clinic or University of Michigan or Holland Hospital, the good hospitals, I would like to have that choice. But a lot of times the Medicare Advantage, they direct you to, oh no, you have to go to this hospital, or no, you have to get a pre-approval from your primary care doctor, or no, you need 3 months of doing some exercise before you can get your shoulder replaced or something. They put some blockages in there, for you. Some people are if you're not sick, that's great. If you have some problems, maybe it's not so great, or maybe you don't care. But we have a very complex, difficult problem. Medication isn't, you're talking about drugs, Paul. I've read where only about half of people over 65 comply properly with their drug therapy. They forget, say they're older, you're not totally, you just forget. I'm not that old, but I have forgotten. I only take one pill, thank goodness. But and sometimes it's expense. I went up to the drug counter I think it was in Florida, and a gentleman went to get his prescription filled, and the technician said, "Oh, that would be like $500." He said, "I can't afford that." He walked away. So the compliance with all these meds that people take is pretty low. So there's so many issues and so many problems. I like what you said, Paul, about which is like a medical advocate for you that would steer you through all this stuff. The computer system now that a lot of people are using it's great, but it's also awful. That my chart, I don't know if you are familiar with it, but now they want you to schedule your appointments and do all this stuff. That's fine for most people, but if you have some vision issue, if you maybe aren't real computer literate, some of these people just can't cope with it. So there's all these different kinds of problems, and I don't know that there is one good best solution. They're just a series of compromises and changes. And I said you've come up with some. I don't know what the cost of that would be if you had a advocate for yourself that could steer you through all this stuff. A lot of people live alone; they don't have a caregiver. Very complicated.
Other questions?
Earlier, I think it was you mentioned monitoring quality control healthcare. On an institutional level, I don't know how you can do that other than measuring morbidity and mortality. And on an individual level, which would be us, consumers of healthcare, most people are not medically trained. They don't even know the questions to ask. I don't know how you would measure those things.
The government does publish. There's what is it? Med grade, health grades. There's certain information, and they scrape the Medicare data, but it's I don't know that it's 4 or 5 star, 2-star. It's based on the data that report to Medicaid, but it's Medicare. But I don't know that it's that informative. It's something, but it's not the best.
So what they do is they do a roll-up of a whole bunch of quality metrics with regard to those stars ratings. And then in addition to that, they do a roll-up with regard to some of the patient satisfaction ratings to come up with these stars ratings. But it's kind of a conglomeration of a bunch of different measures. But the idea is the higher the stars, the better, and to try to give you some level of guidance with regard to that.
So I just wanted to make a comment about that. I do have a high degree of respect for the care that's delivered through Holland Hospital. But on the other hand, there are organizations that try to fill that gap in terms of information. One of them is called the Leapfrog Group. The Leapfrog Group collects data on quality and safety for hospitals and outpatient or ambulatory surgery centers. They do that in two ways. One is a voluntary survey that collects a lot of data about quality and safety, and the other is using readily available information to create a safety score. So Holland Hospital chooses not to participate in the Leapfrog survey. And so that information that would ordinarily be available to consumers is not available to consumers in this area. Because they've chosen not to provide it. So I think transparency is still really problematic in the healthcare industry. It's even more problematic at the individual physician level because statistically, it's hard to get enough information on individual physicians to measure them correctly. But there are mechanisms for it, but healthcare providers need to participate. And our local hospital chooses not to, and that's a disappointment. Just a comment. I don't know if you have any additional commentary on that.
I don't know the history of that decision. But I am familiar with the Leapfrog Group. I did much of my career in Motors community, General Motors and Chrysler. And so they were big into the Leapfrog initiative. So I'm aware of that. And I know they were big pushers of that. I suspect it had to do with, is the juice worth the squeeze in terms of the amount of aggregation to try to get to that point, but I'm not familiar with the background for that decision. Yeah.
I would like to ask you about the increased provision of services through hospice. Do you find that that's making a significant difference in terms of the quality of care and in the cost factors? I'm amazed at how much early intervention there can be in terms of hospitalization, in terms, well, not the hospitalization itself, but the prevention of having to go to the hospital, for providing services, another bed, because the bed is no longer the service that the patient needs. The home care, home health care, I think it's amazing how much they're doing. Is that really making an impact in terms of the financial advantages, or is that adding to it, or is it neutral?
We've been digging into that lately. I will still, the reality and what I'm seeing in the dollars and cents, I haven't seen the impact in terms of the dollars and cents. All of the studies say that it increases life expectancy, it increases patient satisfaction, it avoids wasted services, that it's a win-win-win-win-win for everybody. In terms of the dollars and cents, I haven't seen it yet, but we continue to be a strong advocate, and we've been advocating for that for probably 7 years and continue to try to advocate for that because we believe in terms of the total healthcare experience, it's the right thing to do.
Yeah, I think those services are wonderful for the families and for the patients. And I think physicians and hospitals are, you're not always going to get better. And so I think that's part of the whole life cycle. And I think money aside, even, I think it's really the right thing to do. And people are happier in their home, for one thing, probably less likely to get an infection if they're home as well. One of the other side of that, though, sometimes some of the hospitals, and that is one of the statistics that they do track, they get them out too quick because with Medicare, you get paid like a flat number, a DRG. So if I go in and, get my gizzard removed or something, it's going to be, they'll pay $5,000 or something. But if I stay in too long, then the hospital loses money. So the faster they get me out of there, the more money, more profitable that is. And it's good. It's made systems get more efficient, but you can push them out too quick and they're really not ready for home, or they don't have the caregiver at home to take care of them. And that can be a problem. They do a thing now. They look at your readmission rates, and if people coming back for the same thing, then you're going to get in trouble. But still, it's kind of imperfect right now.
Um, I want to come back to the comparison between the United States system and the European system. I mean, sometimes in these discussions, we act like we don't know how to make a better system, but clearly we know what's working in Europe. And I think you're making the point that we're just not willing to make the kind of compromises. So when I compare the European, listen to what you're saying, the user would have to be willing to take a longer waiting period, and maybe we're not. The insurance companies lose out because it's all, there aren't insurance companies. The drug companies lose out because in Europe they regulate the prices. But the one thing we haven't commented on, and I don't know what the difference is, it is doctors, right? I mean, so the whole system is comprised of me, the consumer, the doctor, the insurance company, and the drug marketer. What's the difference? What's the disincentive? What's the problem, if any? How would doctors react if are they unwilling to go to the European system? What is the question about the doctors? The question to me is, am I willing to wait? The question to the insurance company is, am I willing to get out of business? The drug companies, am I willing to be regulated? What about the healthcare providers themselves? How does that differ in Europe?
I can answer it, but go ahead.
I don't know how it differs in Europe. I imagine you've got everybody of every political persuasion in terms of physicians. They're just like everybody else. They have different opinions with regard to that. So I think it would be perceived differently by different groups. We are, as we have a graying of America, it was mentioned earlier about the graying of our healthcare group and our physicians and so on, that we're frequently rapidly approaching a situation where we're going to have a hard time finding enough physicians to take care of the older America. And so we're going to have to make sure that we're providing enough financial incentives and providing enough support to make it worth the while for people to continue to pursue medicine as a career, because it's going to get tougher and tougher to have enough providers to provide the services as we all get older and need more healthcare services.
I can tell you that in Europe, physicians are paid significantly less. Their average compensation is, in some cases, half of what it is here. And they do have difficulty, more so than here, in recruiting and retaining physicians, and a lot of them actually emigrate to the United States. Leave. Canada has a serious issue with having adequate staff, so that it's a problem over there. I don't want to leave you with the delusion that the European healthcare is a end all, and a lot of why the statistics that I mentioned and where our health, we're not healthy and we spend more money, it's not necessarily the health system, it's us. As Paul said, you know, we don't exercise, we're overweight, it's a lifestyle is different here than it is there. We also have a higher degree of poverty overall than Europe does, which is another significant factor.
We have another remote question from our virtual audience.
You were kind of just talking about not having enough doctors in Europe and Canada. There's a question here about, can you tell us anything about some of the significant delays in receiving readings of x-rays and specialty testing here?
Well, I've had a personal experience with that. I had to wait, not so much lab with radiology imaging. Yes, and why is that? I think it is a shortage of radiologists, but that's where AI probably could make a difference, but there are sort of legal restrictions about that too. The computer can actually read a breast mammogram better than the doctor, but the doctor still gets to take a peek at it and then bill you. So the technology, you know, they need to change the law. I don't know, I go to the drugstore to get my medicine. Do I really have to have a pharmacist take 5 pills out of a bigger jar and put it in a little jar? No, I don't think so. You need to use what they were trained for, which is to explain to you about the side effects and all the issues related to the drugs you're taking. So we do have our structure, both legal and just by custom, probably could be changed for the better.
I can speak to a little more detail with regard to what's happened with regard to that. So first of all, nationally, there's a shortage of radiologists. Secondly, in the world of teleradiology, that there's an enormous amount of remote reading that can take place in this day and age. So radiologists in our market, the radiology practices are not just competing locally, they're competing because those radiologists may sit in their basement and be hired by somebody in San Francisco and read images in California. And so the technology changes and the shortage of the radiologists kind of came together. And then there were some shortages with regard to the number of radiologists available locally. That has been resolved fairly recently. The radiology provider that the hospital works with eliminated some of their other clients so that with the capacity that they had, that they would be able to adequately meet the needs of their existing of their other clients. And then in addition to that, a temporary reading group was added to further kind of get caught up with regard to all of the radiology. And very recently, the radiology read times are back in order of where they should be after having that challenging time with regard to the shortage of radiologists that we were experiencing in our community.
Well, Paul, I will have to say that is a not local problem. That is a national problem. Why, I don't know, but it seems over in the last few years or so that's transpired. So I know in our hospital in St. Joe, they were actually contracted with people in Australia because of the time difference, and they could read it. So you're in the, because the time difference, they could get the readings quicker. So, but it's a national issue, not just here.
Things are changing so quickly technologically. And Joe, you introduced a topic that I wanted to mention and ask about, and that is the use of artificial intelligence. To what extent is that being used in data analysis or in other aspects of this particular topic?
We're just kind of on the cutting edge of that at this point in time. At Holland, there's actually work groups going on right now to try to identify, they've engaged an outside consultant, and they're kind of looking at where would be the different applications with regard to artificial intelligence, how it could be used to streamline work in various different areas, administrative areas too, with regard to how to handle things. So that is recognized as an opportunity, and it is just getting dug into at this point in time.
Yeah, I think that's true across the board with healthcare and education and industry. And we do use it in a certain extent. I think when you get a lot of the MRI technology and robotics actually does incorporate some parts of AI in the analysis of data. But we're just scratching the surface now.
Can you tell us why the insurance companies continue to resist covering health issues that our bodies have from the neck up. Dental, vision, hearing, and sometimes mental health. I have some issues coming up. I've had a dental bill. I have a hearing assignment coming up, and I know I'm going to need new hearing aids. Collectively, they're going to be close to $8,000 or $9,000.
Well, go to Costco for your hearing aids. That was another, in my judgment, I shouldn't call it a scam, but the charges that they had for hearing aids were ridiculous. And actually, I think it might have been Trump, but they changed the law. And you don't have to go through an audiology and pay about $5,000 for each hearing aid, and then you lose it a week later. So actually Costco and other stores now, you can get them that are probably more closely to what they're worth. Mental health, which is interesting. I don't know what your thought is on that, Paul, but mental health, much of the physical health is a result of mental health. So alcoholism, drugs, however you want to categorize those issues. And it's not well funded, it's not well treated, it's not well diagnosed. Talk about a shortage of radiologists. There's a huge shortage in mental health. It's very time consuming process, and typically take a pill for your depression or something, then you gain weight or you don't like it, you quit taking it, then go back in the hospital and back and forth. That's the way we deal with mental health is awful in this country. And I think if they could deal with that effectively, I think I had that one of my slides, but if they could deal with that effectively, I think that would have a very positive effect on the overall cost of healthcare in our country. I don't know what your thoughts are.
We do actually, for our strategic priorities for our organization, the behavioral health is in terms of access, getting people into the programs and so on. I mean, that's a priority for us. I think the insurance companies are beginning to recognize some more with regard to that area. I would say broadly to your question of why don't they pay for this stuff, it probably goes back to dollars and cents in terms of just that they can't make the numbers work with regard to the premium, with regard to that. Specifically to the mental health, there's a lot going on in that area. There's actually counselors that are being placed within practices across Michigan, probably across the country, in terms of co-care management models where there's a behavioral health counselor associated with the primary care office to work with the patients. And frankly, the behavioral health system is so overwhelmed with regard to the needs that trying to deliver more of that care at the front end in the primary care office, because the psychiatrists and their staffs and so on are frequently overwhelmed with regard to the number of patients that they need to see. So on a statewide basis and nationally, what they're trying to do is to push more of that care out into the primary care offices where people may be more inclined to use those services, and to try to broaden the accessibility of those services given the shortage of enough resources.
We are now out of time, so please show your appreciation to Paul and to Joe.
Good job.